Hello, I'm Darina Landa, and I'm the Executive Director of Advancement at the Temerty Faculty of Medicine and Assistant Vice President of Advancement Relations with Healthcare Institutions at the University of Toronto. I'm very pleased to welcome you today to this latest installment in our Temerty Medicine Talk series, where we'll discuss and learn more about Toronto's unique, innovative, and collaborative approach to trauma. Before we begin, I would like to take a moment to acknowledge the land on which the University of Toronto operates. For thousands of years, it's been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still home to many Indigenous people from across Turtle Island, and we are grateful for the opportunity to work on this land. In today's talk, the trauma team, advancing citywide injury care, research, and education, we'll hear about how the University of Toronto is part of a collaboration among 3 renowned trauma centers that work together to elevate the care of patients who experience injuries of all kinds. Together, Unity Health's St. Michael's Hospital, Sunnybrook Health Sciences Center, and the Hospital for Sick Children provide care for the vast majority of our city's most seriously injured patients. All 3 institutions are renowned teaching hospitals and are fully affiliated with the University of Toronto as members of the Toronto Academic Health Science Network. And treating these traumatic injuries requires skilled physicians from across specialties and systems that can deliver timely and often complex care. In this Temerty Medicine talk, we'll learn more about the trauma education, research, and clinical efforts underway, and how the collaborative U of T trauma program is driving a new era in trauma care. I hope you enjoy today's discussion, and I look forward to welcoming you to future Temerty Medicine talks. In the meantime, I'd like to introduce Dr. Patricia Houston, Interim Dean of the Temerty Faculty of Medicine, to say a few words.
Thank you, Darina. It is my sincere pleasure to welcome you to this Temerty Medicine talk. As many of you know, the University of Toronto and the Temerty Faculty of Medicine are the hub of Toronto's world-renowned academic health sciences network. This network of clinicians, researchers, educators, and learners, both on campus and in our affiliated hospitals and our research institutes, work together collaboratively to develop innovative solutions to medicine's biggest issues. Their impact can be felt across Canada and around the world. In today's Temerty Medicine Talk, we will highlight one of the many ways in which we are leveraging the scale, scope, and expertise of this amazing network to facilitate a unique approach to trauma care. Through the dedicated collaboration of our partner hospitals, U of T's trauma program offers novel opportunities to learners, researchers, and care providers in the field of injury care and prevention. I'm proud and excited for you to hear from Temerty Medicine faculty members on how the program is helping them to set a new standard for injury treatment and prevention in Toronto, Canada, and beyond. I'm also pleased to have Andre Picard, the award-winning health columnist for the Globe and Mail. He's here today to help guide our conversation. Andre, thank you so much for being with us. I'm going to turn it over to you now, and you can introduce today's topic and our speakers. Thank you.
Thank you for that kind introduction. Every year in Ontario alone, more than 500,000 people are injured. 1/4 of them are hospitalized, and more than 4,000 die. Whether the result of a relatively common event like a fall or a sports injury, or something more serious like a major car crash or assault, the successful treatment of traumatic injury requires uniquely skilled physicians and health systems that can deliver timely and often complex care. Today, that's what we're going to talk about at the Temerty Talks. Trauma care. Not the nitty-gritty of care, but how you create a system, how you do training and research, and where trauma care is and should be going in the future. We have 3 knowledgeable experts with us today to share their wisdom. Let me introduce them very briefly, but you'll see longer bios in the chat. I'll start with Dr. Najma Ahmed. She's a professor in the Department of Surgery and Vice Chair of Education at the University of Toronto's Department of Surgery, and a trauma surgeon and a surgeon-in-chief at Unity Health in Toronto. Many, many hats. Welcome, Najma. We have also with us SUZANNE BENO. She's a pediatric emergency medicine physician and co-medical director for trauma at the Hospital for Sick Children, better known as Sick Kids. She's also chair of the Canadian Pediatric Society's Injury Prevention Committee and liaison to the American Academy of Pediatrics Council on Injury, Violence, and Poison Prevention. And finally, we have Dr. Avery Nathans. He's a professor in the Department of Surgery, a trauma surgeon, a trauma medical director at Sunnybrook Health Sciences Center in the Torrey Trauma Program, where he also holds the D'Souza Chair in Trauma Research. So as you can see, we have the top trauma experts in Ontario, in Canada, and some of the top trauma experts in the world with us today for this discussion. So I'm looking forward to it. Dr. Avery Nathans, if I could start with you, I want to start with some real basics. You know, we have an audience of health professionals, students, administrators, even lay people like myself. So I want to start with some really basic stuff. When does an injury become a traumatic injury? What's the difference between an ER and a trauma center? Tell us some of that basic stuff.
Excellent question, and thank you. I think this is an important level setting, so we're all talking about the same thing. So when we talk about trauma, we're talking about injuries, and injuries clearly occur across a spectrum. The way that trauma centers and trauma systems are set up, they're designed to get the patients who require complex multidisciplinary care, i.e. team-based care, to ensure full recovery. So for example, you know, your local hospital might have an emergency department. That emergency department will be able to manage or at least identify potential injuries that you might have, and if necessary, send you on to the right specialist or deal with the injuries right then and there. The types of injuries we're talking about are typically at the severe end. So high-level falls, motor vehicle crashes, gunshot wounds, stab wounds, injuries at that level that require a team of experts to be able to identify what specifically the problems are and to address each of those injuries in a very time-sensitive fashion. So what's unique about a trauma center is that they're immediately prepared to take care of just about anybody and anything, because all of the resources, the people, the operating rooms, the CT scans are all immediately available.
And does traumatic injury mean you're at the risk of death, or does it just have to be really bad?
You're either at the risk of death or at the risk of severe permanent disability, like spinal cord injuries, for example, losing an arm or a leg. So permanent disability or at the risk of death.
Dr. SUZANNE BENO, thank you for joining us. Now, you work at Sick Kids. You work with the younger set. Is trauma care different for children, or is it more or less the same thing? It's the really bad stuff.
Yeah, thank you. It's a pleasure to be here. The approach to trauma is universal and standard across all ages. So it has to be standardized, it has to be, comprehensive, it has to be efficient and effective response. And there are some unique nuances to children for sure. So they have different physical, emotional characteristics. The younger they are, the more pronounced those differences are. They have some differences in anatomy that predispose them to different types of injury patterns, and lower rates of surgical intervention. For an example is a different management strategy. Their physiology is a little bit different, so responses to hemorrhagic shock and blood loss are a little bit different. And then of course there's unique considerations around their developmental state, how they regress with stress, and there are skills that we need to focus and calm a child in the trauma bay, for example, as well as utilizing family-centered care. So while the general approach to trauma care is universal, there are some nuances that we use.
As a parent myself, any injury to a child seems traumatic to a parent. Do you have to say to some people, well, you don't really need trauma care?
Well, we have different triage categories in terms of, how significantly injured a child is. If they meet activation criteria through field trauma triage guidelines, or if when they present to our emergency department, it seems like they're a significant risk to require a trauma team response, then we would employ that then.
Okay, great. Dr. Najma Ahmed, thanks for joining us here today. Now, you work at St. Mike's, which has a kind of a different clientele, the inner city clientele, lots of traumatic injury, also lots of mental illness, addiction, homelessness. How does this very unique population, how does that change your approach to trauma care?
Yeah, it's a great question. And just as Dr. BENO has outlined, the approach is universal and the standards that we use are very similar. But our patient population being in the inner city, as you have outlined, is at increased risk for certain kinds of adverse outcomes. So there's a lot of emphasis in our trauma center on prevention. There's a lot of emphasis on management of addiction and mental health issues once we stabilize those patients from their traumatic injuries. And we know, and the literature shows, that this does improve outcomes and decrease the chance that they're going to come back with a traumatic injury in the future.
And we heard from Dr. BENO, you have to treat children a little differently. Is it the same with, say, someone with mental illness or homelessness? They might be scared to actually be in the hospital.
Yeah, it's a really very, very good point. And they're often in a situation where they're not able to advocate for themselves, and they don't have family supports and social supports that can enable the best outcomes and recovery. So we spend a lot of time on that, and we try and advocate within the hospital and outside the hospital for additional supports, sometimes non-physician supports, social worker type supports, and community supports to ensure that these patients, once their care in the hospital, the medical treatment has been wrapped up, we can address the other issues that can ensure they have the best outcomes.
Yeah. Dr. Nathan, yeah, go ahead. I was going to.
So Dr. Ahmed's comments are right on. So, we're talking a lot about injuries, but the reality is many of these patients present to the trauma center because a lot of things that are going on around them. There's often mental health challenges, there's social challenges. And I think trauma is one of those areas where you actually do try to achieve equitable care. So those individuals that have these additional challenges, they're now brought to our attention, and we bring the resources they need to be able to get back to where they would otherwise need to be. And we have programs to help with that, but we're somewhat unique in trying to address, honestly, the social determinants of health at the same time as we're dealing with the injuries.
And I've heard you say in a talk before that trauma patients have no voice and no choice. And I was thinking that when Dr. Ahmed was speaking. Can you speak to that concept?
Yeah, it's actually quite a broad concept. Unlike you choosing a surgeon or your doctor to deal with a non-time sensitive problem, when you're confronted with a severe injury, you probably cannot speak. You're probably not going to be able to choose your hospital, which means the system needs to work behind the scenes to get you to the right place at the right time. So again, you have no choice and no voice. And Dr. BENO mentioned the field trauma triage criteria. So what does that mean? How do we identify the patients who need to go to a trauma center? We work closely with EMS, the paramedics across the region, to align on what sort of patients need to come directly to a trauma center. And that leads to probably the most effective approach to care because it reduces the amount of time between injury and ultimately identifying the problems and dealing with them. So field trauma triage criteria is one approach that we assure that patients with no voice and no choice get to the right place. Dr. BENO also mentioned triage criteria. In our own hospitals, we have the emergency department and we have the trauma bay. Trauma bay is where the sickest patients go. Each of our centers has a way of identifying those patients if they just walk in or they're brought in by others, which patients have to go to the trauma bay and which patients need to be cared for by an emergency physician. So what I mean by no choice and no voice, the system has to work behind the scenes to make sure everything happens as it should every day, 24/7.
And you mentioned the system a couple of times. Do we have enough trauma centers? Are they in the right place? That's a big part of what we want to talk about today.
So I can comment on this and perhaps others can chime in too. We have in Ontario what's called an exclusive trauma system. It's like an exclusive club. You're either a trauma center or you're not, which creates challenges because we've got a very large geography to cover as a province. And, the population centers are relatively few and far between and highly concentrated, which means if you're injured in the wrong place, it's going to take you a long time to get care. And what we've recently been advocating for, and this is now happening, is a more inclusive system where we have what we call level 1 trauma centers, which are responsible for educating the trauma providers of tomorrow. do research, provide comprehensive care, but we're also working on developing level 3 trauma centers, which are those hospitals that are strategically located within the province, and they have the capacity and the skills to take care of those patients and keep them in the community, and those that may be beyond their resources, they can send on to us. So this inclusive system is one way that we're changing Ontarians' access to care in a very positive way. And Najma, Suzanne, any comments?
Yeah, that's great. That's a great foundational, fundamental description of the system. And I think in Ontario and across Canada, we've done a great job at setting up what we call lead trauma hospitals or level 1 trauma centers, which are the places where people like Avery, myself, and Suzanne work. But as Avery's outlined, there's a huge geography of patients who will not have immediate access. So the next evolution and what we must work to do is to ensure that in smaller communities outside of urban centers, there are experts and physicians and hospitals and systems that are integrated into the larger system. So patients who have perhaps less severe injuries that can be managed in their community can be managed there safely, and then patients who require the whole team of experts at a level 1 center can be sent down to urban centers. This will ensure that a wider swath of the population is receiving the best care, and it helps us to integrate with providers in the community, helps us to learn what the needs of those communities are, and helps us to provide education for those people who are providing that care in those communities to those patients.
Now, again, as a layperson, I think I don't want level 3 care. That doesn't sound as good as level 1. Is that how we should look at it?
I always say no to that question. This isn't first, second, and third best. Each of the centers has a specific role to serve the community. And if everyone came to a level 1 center, they wouldn't necessarily receive better care. They would just travel further from home to get that care. And for patients who really need the level 1, they would not be able to access it because we'd be full. So I say that like level 3s have a very specific role in serving their communities, as do level 1s. It's a different role and complementary, and all are necessary.
And Dr. BENO, on that same theme, we have very few pediatric hospitals in Canada. Not everyone can come to sick kids. How do you make sure that kids get trauma care everywhere, Northern Ontario, at the cottage, et cetera?
Yeah, that's a very important question. And it's a really good point, because through North America, both in the United States and in Canada, we know that the majority of children are not actually seen at tertiary pediatric specific hospitals, even for non-trauma related conditions. So about 80% or so. And we know that even at our pediatric trauma centers within Canada, close to 50%, sometimes even a little higher than that, are children who are stabilized, initially seen stabilized at a community hospital, and then transferred in. So there's a large proportion of children who need to receive good quality pediatric specific trauma care out there who aren't going to get that at a pediatric center. There just aren't that many pediatric trauma centers available in Canada. So one of the ways that that's been dealt with, because it's certainly recognized as an issue, is around pediatric readiness. This is a concept that really is the same sort of same as what Dr. Nathan's alluded to, is that everybody gets the same care regardless of where you are. And so that's a movement that was started in the United States, and we've adopted it informally and formally here in Canada. So for a number of years, there's a Canadian national organization called TREC, which is translating research into emergency care for children. And that's been a national project and organization that really works to make sure that everybody looking after children across Canada has the same information, point of care tools, and ability to resuscitate children for common conditions. And trauma is included in that, both multisystem and severe head trauma. And then recently in Ontario, we have some champions who are employing the same surveys that have been used for pediatric readiness in the United States, and surveying our scope in Ontario. And there certainly are areas where we can where we need to identify, or that have been identified, that need to be addressed. So there are some basic things that would go a long way towards safe and timely care for children that aren't necessarily routine in adult or general centers. You know, that's even just establishing that children are always weighed in kilograms as opposed to potentially pounds, or having a champion like a pediatric emergency care coordinator, or ensuring that somebody is looking after the pediatric resuscitation cart to ensure that the right equipment and the right medications and the right cognitive aids are there to help somebody in the heat of the moment who's not used to dealing with children have to resuscitate a child.
Now, Dr. Ahmed, trauma care is hard work. I think that's been implied in what you've all been saying, mentally, physically demanding. It can even be traumatic, I imagine. So how do you ensure the well-being of staff and trainees who work in this area, who deal with really serious cases?
Yeah, it's a great question. Certainly there's a lot of stress in the healthcare system, but trauma, I think, is sort of the pinnacle, the coal face, where the whole team comes together with someone who may have very severe life-threatening injuries and is at high risk for dying or having severe disability. And we see some pretty awful things. Sometimes, you know, we have great outcomes. Sometimes there's a magic that happens. The team comes together, patient gets resuscitated, they get all the right treatments, and they have a pretty good outcome, albeit after you know, prolonged hospitalization. But sometimes things don't go so well, and even when things go well, it takes a long time and it takes its toll on healthcare providers. I think the first part, the way I would answer your question is to build awareness. There is vicarious trauma, and we all feel the stress and strain of it. And the second part of it is, after we have an awareness of it, is to feel comfortable and empowered to talk about it and discuss it with our peers and beyond our peers. So there is an increasing awareness in healthcare communities that it's important to discuss when we feel overwhelmed. It's important to support our trainees, as sometimes they're seeing these things for the first time, and they can be very, very dramatic. Some person who was driving to work that morning left their home, left their family. All of a sudden, they're, you know, inches away, moments away from death, and it can be very traumatic. Having to manage that patient, discuss these things with the patient's family. So part of it is to recognize it. The second part of it is to talk openly about it. And finally, I think we need more supports for all of the providers in the healthcare system when they feel they're overwhelmed and they need supports.
And real life isn't TV. Not everybody can be saved.
Real life is not TV at all, and even when they are saved, as I said, it can be a long and difficult process for patients. Often they're, you know, I think people have this image from TV, as you say, Mr. Picard, that the ambulance comes up to the ambulance bay, the paramedics rush the patient into the emergency department, the trauma bay, the doors close, and then I guess people imagine that all the doctors and nurses and other people descend on the patient, and the patient gets better and they go home. But actually what really happens behind the scenes, if the patient has severe injuries, is that that patient can have multiple operations, be in the ICU attached to life support machines for prolonged periods of time, have multiple CT scans, multiple specialists, as Dr. Nathans has mentioned. One day it'll be the orthopedic team, the next day it'll be the neurosurgical team, the next day it'll be the trauma surgery team that's operating on that patient. That patient can have 6, 7, 8, 10 operations over the course of hospitalization. Then they're after they leave the ICU, they're in the hospital for a prolonged period of time, and then a lot of rehabilitation before they finally get well enough to think about re-entering into society. So I think all of that takes a toll, and the recovery is not linear. Sometimes the patient gets better for a few days, and then sometimes there's a problem and they go back. All of that is a difficult thing for the care providers and certainly for the patient and the family.
Yeah, I will
Dr.
say,
Nathans, I was going to ask you to build on that. You know, if anybody who's been in trauma care knows it's probably the worst day of their life. They don't always come out the same. You know, do you have to do follow-up, or do they just get forgotten after they leave
I'm going to say that, I was just, sorry, I was just going to say that, yeah, these patients are often never the same, and they're in the prime of their life, right? They're often young people, and very often our patients don't go back to work or go back to school for many years. And we continue to follow them in the rehabilitation phase, but we need more of that. We need more of post-injury support for the patient and the family to be sure they get to to ensure they get to be the best version of themselves after their injury. If I was going to let you add, you probably have something you wanted to add to that.
Yeah, certainly around the initial resuscitation. We love what we do. We love being there at, unfortunately, a patient's probably worst moments. We love doing that. To deal with that stress, we often provide some space immediately after the resuscitation to have a hot debrief. We call them hot debriefs here, where people can speak about what they saw, what they did, can they do it better. That space allows people to kind of just absorb what's happened and also share in their feelings. In terms of getting people back to where they need to be, the old approach to trauma care, and I'm proud to say that the U of T trauma program has done a lot to try to correct this. The old approach was you patch people up and you send them home. Okay, so nobody else does that. You have a heart attack, you see your cardiologist, they put you on aspirin, they put you on all these other medications so it doesn't happen again. We have now worked together, and we probably all do this a little bit differently, but we realize the importance of trauma survivorship. So I know at our place, and Suzanne and Najma can speak to what they're doing, we've created a survivorship clinic that addresses the mental health issues that occur after injury, the physical functional challenges. We provide physio and occupational therapy. We have traumatic brain injury experts to deal with the sequelae of a bad head injury. So we don't now patch people up and send them home. We now wrap everything around these patients to get them back to where they need to be.
Good. And Dr. BENO, we just heard about hot debriefs, but at Sick Kids, you do video reviews of all your cases. Can you talk about that and why you do that?
Yeah, absolutely. So the video review program is something we actually modeled from Sunnybrook, to be honest, and also some pediatric centers in the United States that have been doing it for some time. And it's a great quality improvement tool. So we video review all of our trauma resuscitations. And then based on, certain criteria, usually it's around clinical acuity. So kids that are particularly sick, or if there are some, if there's an issue, either positive or negative, brought by any team member to me or our team to review, then that meets criteria, and we review those kids. And then we have a small committee that reviews. We have some metrics, and then we decide which child we're going to present as a patient care or a video review session. And that's really meant to be a systems approach. It's never about individual performance. It's always about how the team did within the trauma system that we have. It's attended very well. It's multidisciplinary, interprofessional, and we've received really great feedback on it so far. And it's been very instrumental, actually, in pushing our quality improvement program forward. So we're really happy that, by using this kind of program, we've been able to advance some of the goals and the agendas that we had, and people feel it's invaluable to actually see themselves and see others and be able to emulate great care when we see it, and then also to see where we stumbled on that. We keep stumbling on that, and it's like a tool that people can not only hear about in a session, but also see, and it sticks a little bit more that way. So it's been very, very effective.
It's a good example of how we actually do things across all of our centers as the U of T trauma program. Like, that is a perfect example of that, I think.
Yeah,
that's I want to ask you to build on that, Dr. Nathans. We've talked about generalities, but talk about the U of T program and what's unique about it. You're responsible for a pretty big area, and you're doing things a bit differently, as you mentioned.
Yeah, we're doing things together. I would say probably prior to 2010, each trauma center did their own thing, and there wasn't a lot of interaction. Probably around 2010, 2011, we started working together and identifying ourselves as a singular program. And that singular program, initially, the focus was primarily around training the clinicians of tomorrow, because trauma is a pretty niche area, and we want to make sure that there's enough capacity out there to be able to care for patients. So we initially got together over developing a shared, if you will, educational curriculum, and identifying opportunities to bring learners in from outside. And these are often people who've done their residencies already and their fellows. They want to learn more and bring it back home. So we created a shared fellowship across the centers. We've also moved forward in developing several research initiatives that cross all of our centers. And as Dr. BENO mentioned, we're also sharing quality improvement ideas. Again, because patients have no voice and no choice, the onus is on us to make sure that care is as good as it could be at every moment. So we're always evaluating how we deliver that care, and we share those ideas across the three of us, three centers. And Najma, Suzanne, any additional comments around how we work together?
I would just add that this collaboration has been, really inspiring, and we learn a lot from each other every day. I think maybe the people imagine that at our stage of career, there's not much more to learn, but in fact, every time we discuss a patient or a quality improvement project, or how we're doing survivorship, how we're doing at St. Mike's compared to what's happening at Sunnybrook, there's always something to learn. And this collaboration ensures that we learn from each other and build on our strengths, identify our weaknesses, and build on our strengths. And in this way, my sense is that we are becoming a model for how this can be done across the country. Other university-led trauma centers across the country are beginning to emulate what's happening here at the University of Toronto because of the successes that we've had.
And Dr. BENO, probably most trauma people around Canada have come through U of T at some point. You do a lot of training. Can you talk about that, the spreading of your system and your ideas?
Yeah, it's so great actually to have so many different residents and fellows who come through, and we have even on the pediatric side, which trauma is niche, and then pediatric trauma is like additionally niche to that. And so we have lots of our fellows who then have gone on. They complete a trauma fellowship here with us at SickKids, and they've gone on to lead and direct their trauma programs across the country. So, and we have quite a tight network within Canada. And it's great. And, along the lines of the U of T trauma program and collaboration, I just can't thank our centers enough, both St. Mike's and Sunnybrook, because our fellows, both, emergency, general surgery, trauma fellows, spend time over there and have fantastic experiences. And we collaborate on lots of stuff together. So, so I think it's been wonderful, as a wonderful initiative to grow this and continue to work together.
Now, Dr. Ahmed, we've talked about, a little bit what goes on in the trauma bay. We've talked about the system, but you are also an advocate for gun control, about intimate partner violence, bike helmets. Talk about that aspect of trauma, preventing it.
Yeah, it's such an important thing to talk about. Often we talk about trauma, sort of in the lay press and in the lay public talk about accidents, but those of us who do trauma as a career, we know there are very few accidents. The vast majority of these injuries we see, many of them, are preventable. And physicians had a strong role in this, always as being advocates for not only the patient, the individual patient they serve, but for the populations that we serve. Think about tobacco or seatbelt laws or road traffic design. There's many examples. Asbestos. We see the ill effects at the coalface where we work of poor public policy, or how we can work to make the health of our populations better. And so, yeah, we sadly across the country, all of us who work at trauma centers have noted an uptick in the rates of gun violence, the kinds of injuries we're seeing, the numbers of victims when we see them in our trauma bay. And we compare ourselves to the US, and we think falsely, I believe, that we're doing okay. Whereas when we compare ourselves to the other economically developed countries of the world, we're not doing okay. We can do better, and we must do better, in fact. So, yeah, this is part of the work of all physicians, actually, or, the physicians who choose to do this work, is to think about how we can prevent these injuries, to engage with policymakers, to think about what is evidence in what the evidence tells us about how we can make our societies safer. And I've been very fortunate to work with many experts, trauma surgeons, emergency physicians, nurses, public health policy people across the country. So it's a national effort, and it's been very gratifying.
And Dr. Nathans, I'm trying to work in some, there's a lot of good audience questions. And one of them is sort of related to what Dr. Ahmed said, like who does this well? Who's doing the best trauma care in the world? And how can we learn globally, not just locally?
So we are doing this well. I will say, we participate in benchmarking programs that compare the U of T centers with the best of the best. And you know, we're easily in the top 10% of all centers. But where we're unique is the ability to work together and to innovate. So, you know, you've heard a little bit about the advocacy piece, but the education piece, the research piece is also important. And in most environments, you'd have one trauma center competing with another trauma center. We don't do that. We have done interventional trials. What I mean by that is we don't know the best way to give blood transfusions in patients with trauma. You know, we have trials that are going on across both of our centers and involving our EMS partners to give blood in the field to understand what's the best way of doing this. We have scientists working with us to try to understand how can we get patients to recover better from spinal cord injury with stem cells? How can we stimulate the brain to get a patient back to where they were after a severe brain injury? So we work together actually in trying to develop either research protocols or the right questions to be able to advance trauma care to the next level. And I think we've learned a lot from each other because there's a lot that happens within the hospitals. There's lots that happens outside of the hospitals that we bring in. So for example, we brought in the Center for Healthcare Engineering, which is you know, a department at the university, and said, how can we design our trauma bay so we can provide more efficient and more effective care? Engineers being brought to this environment is an amazing opportunity. How we communicate in the trauma bay, you know, we learn from each other by looking at each other's videos, but who ever thought that improv, Second City, SCTV, improv actually has a very important role in providing us with new insights into how we can communicate in an interprofessional way in a high stakes environment. So we're bringing creative ways into the program so we all learn to improve the quality of care.
Great. Now, Dr. BENO, I've resisted, but there's lots of audience questions about this, kind of related to SCTV, but people are intrigued, you know, is trauma care the way it is on TV, you know, Chicago Hope and ER and Grey's Anatomy? That stuff is pretty chaotic and frightening. Is that what it's like in real life?
So generally, no. Like what we see on TV is not exactly what we see in the trauma bay or emergency departments. Controlled chaos sometimes is what we're going for. We know that when they're high acuity, low occurrence situations, we train for that. We practice that. We have all our systems in place to try and make it as controlled and organized as it can be. But sometimes there is a little bit of chaos. But it can be dramatic, but it's I don't know how to say it. it's not TV. We're trained in a systems-based approach for every patient, for multiple patients, to keep even the chaos under control. I don't know if that's a good answer, but
and it makes me, as a potential patient, gives me some comfort that it's not like on Chicago Hope or whatever. Nobody's arms getting cut off by the helicopter every second day or anything like that.
So we also borrow great ideas from other groups. So Dr. Ahmed at her center has a Canadian Forces physician. You know, they know how to manage crisis. We have the Canadian Forces come to our center and we learn from them. Like they know how to work as a team very differently than docs do and nurses and the rest of our team. So we learn from them and they learn from us.
So we only have a few minutes left. So I want to talk about the future. Where is trauma care going? Maybe you can start us off, Dr. Nathans. This is a big city. It's growing. Do we have enough? You know, are we planning for the future? And then we can talk about some of the nitty gritty. How will it be different?
Yeah. So I think we're beginning to plan for the future. The greater the population, the more trauma centers we need, and the more learners we need to train to be able to provide that high quality care. So we're looking forward to the growth of medical schools in the city. We're going to be training many of those learners who will fill those hospitals with the right skill sets to take care of those patients. So I think I'm confident, and others can chime in, around our ability to train the folks of tomorrow. Where I think there's the greatest opportunity is building upon all those things that are happening across the university and across our centers and bringing them together. So I mentioned, stem cells for spinal cord injury, the things we can do with traumatic brain injury. So there are scientists across the university who really understand artificial intelligence. Imagine bringing one of those scientists in so they can look at a CT scan. They can know how to analyze a CT scan and every pixel on a CT scan, and using their analytic approaches, tell us this patient needs this therapy or that therapy for them to get the best possible care. For us, we just look at a CT scan, it's black and white. For someone with those analytic abilities, it changes the game completely. So we need to be able to bring all of that innovation that exists across the university to the table so we can really innovate and advance the care of injured patients. So I think there's probably so much opportunity in that space, but I know there's opportunities in the education space and the advocacy space as well. Trauma is one of those things that it's the intersection of acute care and public health, that there's just so many ways to do things differently. But I've spoken enough.
And Dr. Ahmed, talk a little bit more about that intersection. In the future, can we do more prevention? Can you work yourself out of a job someday?
I hope to work myself out of a job. That would be great. So I totally agree with what the comments that Dr. Nathans has made. And I would add, I think the future should include, not only for trauma, but for all disease states, focus on prevention and public health. This is very, very key. I would like to see fewer patients come to our trauma bay. That would be the best case scenario. I think, as we've talked about through this whole talk, collaboration through just all the three centers, the University of Toronto Trauma Center, University of Toronto Trauma Program, but also beyond Toronto to the other across universities in Canada and across the world. We can learn so much from each other through collaboration. And was mentioned in this talk, the emphasis and importance on survivorship. This is very, very key. Our job does not end when the patient leaves the hospital. Our job has to continue, and we need perhaps a different kind of care provider to work with communities and to work with those patients at home to be sure they recover to the fullest extent. Maybe Dr. BENO has more to add.
Yeah, I was going to ask you specifically, maybe on the research front, is there gaps there where we should be going for the future, Dr. BENO?
Well, absolutely. So I 100% agree with everything that Dr. Nathans and Dr. Ahmed said. I think it's so important that we view trauma as injury control with a focus on prevention and rehabilitation survivorship now, in addition to acute care. With regards to research with trauma specifically, I think large networks, collaborative research, global networks is really how we're going to get the answers that we need to really move the dial on care processes. So particularly for children, where our trauma volumes are significantly lower in children than adults. For example, we really need to and have developed large global research networks to address these questions. So I think, things around neurotrauma and the extrapolation early in care, or the best approaches to managing hemorrhage, identifying hemorrhage and shock early, transfusions, so forth. Sometimes a lot of the stuff that we see in children is extrapolated from adult literature or military settings. And there's a significant amount of work that's being done to do, large scale prospective work that's applicable and generalizable to the children that we see in our population. So I see that kind of research as being part of our future as well.
Okay. And Dr. Nathans, there's never enough money to go around. Resources everybody's fighting over them. What would you do if you had more money? How would you make the system better tomorrow?
So I'll just say, I've been fortunate. I was the recipient of the D'Souza chair, which is now coming to an end, and there'll be a new chair holder. But the monies from that chair were just phenomenal in allowing me the opportunity to really train many of our residents and others doing masters or PhDs to really focus on trauma research and to ensure that we're innovating as a group. So while I may have a particular trainee working on a particular project, that touches all of us. And my hope is that if we had additional investments in the program, we can expand those opportunities across all of the centers and also bring in that expertise across the university. So we're having very different perspectives brought to the questions that we face every single day, whether it's AI, whether it's survivorship. We don't know why one patient does well after an injury and one doesn't. It's a mystery. But the keys to that mystery are somewhere on campus. I know that. We just have to bring it out. And I think those resources would help us bring out the answers to those questions.
Yeah, it's a good reminder of the importance and the impact donors can have, especially in this area. We're almost out of time, so I want to ask you one last question each, a 20-second answer, because we have a lot of learners in the audience. Tell them why they should come and work with you in trauma care. Maybe you can start, Dr. Ahmed.
Well, I think the answer is, I'll tell you the reason why I decided to do trauma care. Because every once in a while, it doesn't happen every day, but every once in a while, something magical happens in the trauma room or the operating room where you get to save someone's life. And you get to witness that. And it is really profoundly satisfying. It comes after a ton of training and a ton of work, and the whole team has to be bring their A game. Every once in a while, we get to see an amazing outcome where someone's life was saved, where maybe their life would have been lost, but for the team that arrived in that trauma bay on that day to manage that patient. I think it's one of the most gratifying things that I'm involved with in my career.
And Dr. BENO, what's your pitch?
Yeah, I couldn't agree more. I can't think of anything more rewarding than working with a team to save a child's life, to develop relationships with that child, with that family, and just to see what an impact our care has. So I think it's an amazing job. There's not enough of us in pediatric trauma, so I would definitely encourage people to come, but you wouldn't be disappointed. There's so much reward.
And Dr. Nathan's final word of inspiration to our audience?
Yeah, I think, honestly, a lot of what docs do and healthcare providers do is noble, but I think we have a very noble profession in providing trauma care. Patients trust us to do what we need to do without a lot of questions, and we try to do the right thing. So it's a very noble thing to do. Usually occurs at off hours and very challenging scenarios. But my personal satisfaction comes from seeing very positive results. And some of us are in this because we like instant gratification. I will say that we're impatient. But working with the team, like you really, really understand and value every member of the team. Everyone contributes something. And it is amazing to work with such high-level professionals every single day.
Great, and thank you all. I wish we had more time. A fascinating discussion. Thank you, Najma Ahmed, SUZANNE, BENO, and Avery Nathans for joining us today. Thank you to the audience for joining us for Temerty Talks. Please stay tuned online. We'll have your email now. We'll tell you about upcoming talks. And please stay safe. Nobody here wants to see you in their trauma bay, but they want to see you working with them. So thank you again. Till next time.